the case study is of a female who was age 51 at the time of presentation. That was in 2019. She had had complaints of low abdominal pain and genital sores for 4 months. And so she went to a local clinic for screening for cervical cancer by visual inspection with acetic acid, and the findings were normal. So then she was referred for further investigations, and she had a biopsy taken and histology done. And some background information also is that she had been on HIV treatment from 2011. So she first presented to Cancer Diseases Hospital in 2019 in October, and the diagnosis was locally advanced vulval cancer type, locally advanced and invasive. Figure staging was stage 3 at the time of starting radiotherapy. So summary of the treatment was that she had chemoradiotherapy. She had 1 cycle of cisplatin, and then she had 46 gray radiotherapy in 23 fractions. This was started on the 7th of April, and her last session was on the 12th of May in 2020. A point to note was that she did not get a boost, so her treatment was considered incomplete. The initial patient problems was that she had localized genital pain, obviously because of the sores, and then she had bleeding. And then she was on paracetamol 1 gram 3 times a day orally. And also she had an encounter with the palliative care team. So this is something that the hospital tries to do to ensure that every new patient has an encounter with the palliative care team and starts interacting with them. So she had counseling, and then also they had a relook at her pain meds. Then during radiation therapy, at 17 fractions, she developed constipation. The genital pain seemed to have increased. So they added morphine and lactulose to her analgesic regimen. And then immediately post-treatment, she was seen and she had continued problems of abdominal pain. And then the perivalval sores were necrotic. So she was prescribed wound care twice a day, which involved sitz baths. And then she continued on morphine, 5 mils every 4 hours, plus bisacordyl 10 milligrams nocte. So this lady was treated as an outpatient case. So mostly she would just come in for treatment and then she would go home. So any interventions were obviously through health education and then encouraging her to carry out those interventions for herself at home. And then she was followed up at 6 months post-treatment. The genital pain continued, so the anti-pain meds were continued. And then at 1 year, again, she was seen. So she was being followed up now every 6 months. She still had complaints of low abdominal pain. So the pain meds were continued. And then she sort of dropped off the radar, and this was during the time of COVID. So a lot of patients were not showing up, and there were travel restrictions. So she was now seen about over a year later when she came in with a complaint of swelling in the groin, which had been there for about a month, and then also lower limb pain. And on examination, she had a left inguinal lymph node that was about 2 by 2 centimeters. There was vaginal stenosis, and the doctors requested for a Doppler and a CT scan to rule out recurrence of the cancer and also deep vein thrombosis. So she was continued on analgesics, and at this point, she was taking tramadol in addition to the paracetamol, and the morphine had been discontinued. Then again, she fell off the radar after doing the CT scan. She came back now at 3 years and 4 months. And the left inguinal lymph node, it showed that this was metastatic. This was from the CT scan report. And the Doppler confirmed the deep vein thrombosis. So she was commenced on Clexane 60 milligrams once a day. And she only took this for 14 days. And she continued on the tramadol. And there was a recommendation for her to be reviewed in the gynae oncology clinic for fine needle aspiration of the lymph node. So this was done, and it was confirmed from results that there was recurrence. So the swelling in the lower limb was progressive, and then the left lymph node now became a fungating nodular mass. So at this point, she was ECOG 1 in performance status, and the recommendation was for her to have palliative chemotherapy of carboplatin and taxane for 6 cycles, which she completed in September of 2024. Her last visit to the hospital was this year in January on the 23rd. And the lesion had expanded and grown, and the lymphedema also now had increased extent somewhat. She was now ECOG 2, and she continued now on morphine. She was put back on morphine because her pain was unbearable. And then also there was a recommendation that the ulcer is treated with crushed metronidazole because it was foul getting and foul smelling. And now her mobility also had become severely compromised, and she was quite dependent on care. The version of the case study was one of for the radiation therapy, and also she should have had 3 cycles of chemo, but she only had 1 for the chemo radiation therapy. And then also there were all these gaps in her follow-up, resulting in delayed interventions for the problems she began to develop. So the issue is now, how can nurses provide optimal follow-up remotely between visits, or link these patients to their local primary healthcare providers for care? Because like in her case, there was a great need for wound management and pain management. And the point to note is Cancer Diseases Hospital is based in the capital city. It's the only cancer center for the whole country. Got through the presentation, so now we can discuss and have questions and contributions. Thank you.
Biemba, I have some questions just regarding payment for services in your area. Is it you have to pay per treatment? Is that part of the reason that you believe follow-up may not have been as close for this patient?
Well, treatment itself is free, but some investigations people pay out of pocket. And of course, accessing a healthcare facility is at the patient's own cost. So the economic factor sometimes is a huge impediment to patients accessing care. That's why sometimes people have missed appointments. Because, for example, if they come from halfway across the country, they don't have any family in the city, it becomes very difficult. And sometimes they have to raise the money that they have to pay for transportation and also have some money to support their stay while they're in the city accessing care.
Thank you.
Biemba, here in Australia, we have something called IPTAS, or travel allowance schemes, that the government provides patients who live a certain amount of, more than 100 kilometres away from their nearest treatment centre, some financial support. Is there anything like that available to your patients?
Unfortunately, no. The only thing is, usually when a patient is referred for specialist care, sometimes there may be an ambulance service at their first visit, because sometimes even the ambulance service, there may be such challenges as maybe there is no fuel at that point in time. And also because of the cost involved, they may have to wait a little so that it's a combined trip with some other services. So currently there is no transportation support. Although at some point the Zambian Cancer Society was running a service called Hope Transport, where they would engage the commercial passenger services who would offer free tickets to patients. And sometimes the social workers department is able to find well-wishers who can subsidize patient travel. But this is not very reliable or consistent.
Another question was going to be, so she had incomplete treatment. The reason behind that, especially the boost, she didn't have that? Was there a reason behind that?
Unfortunately, in the case notes, there was no detailed information as to why the treatment was incomplete. But a point to note is by this time, our radiotherapy service was limping, and sometimes our machines would be down because our machines had been in service from when the hospital opened in 2006, especially the linear accelerator and the initial Cobalt 60 unit. And then we had a second Cobalt unit that was a Babatron that was procured in 2016. Our brachytherapy unit as well was one that had been around from the time the hospital opened. So by 2019, our machines had more downtime than uptime, and that would disrupt treatment.
Yeah, absolutely. We had our national gynae-oncology meeting here in Australia last week, and there was a radiation oncologist from Rwanda who presented, and similar type of situation where, you know, the Linacs were out of action, you know, a large amount of the time. That really had an impact on being able to provide treatment to patients.
Biemba, do you know if the boost was going to be external beam boost or a brachy HDR boost?
Yes, and at present, right now, question, but I was also going to add that we have had no 2022 working, and because of age, spare parts were no longer available. Currently, the government has procured new machines, and the bunkers are being redone. So hopefully, before the end of the year, radiotherapy services will be back on. So what the government did is we're having to send patients out of the country to India at government cost. But obviously, you can only send so many patients at a time. So our waiting list for radiotherapy is actually over 1,000 patients currently.
Thank you, Biemba. In the beginning of you answering, it completely cut out. We heard, I think, the second half, but we did not hear if it was going to be an external beam or a brachytherapy boost. You cut out for that part.
Okay, so this lady was obviously going to need brachytherapy. But like I said, at that point, our machines were mostly down than working. So you find that a good number of the patients, even on external beam, would not complete all their treatment in the allocated time slot. So they would have to discontinue treatment until the machines were fixed. And for some who come from far away, that would have an impact on whether they came back in time to complete their treatment or not. So we've had a lot of progressive disease and recurrence, I think, in the recent past because of suboptimal treatment.
Thank you. Yeah, I was able to hear all of that this time. Do you find that with the HDR units in particular, with the brachytherapy units, do you see more issues with support for when the machines break from the vendor, or is it also sources getting stuck in customs for source exchange?
Well, for source exchange, like because we were using it was an iridium afterloader, so sometimes it would be transportation. All the paperwork would be done and all, but you'd find that finding an appropriate flight that can carry radioactive material would be an issue. And then sometimes also it would be issues of processes and procedures really to get the payments cleared, because we are a government-funded institution and it operates based on public funds. And so we usually have to get clearance from headquarters for anything that we're doing. So sometimes you would have delays in the brachytherapy source being brought in when the old one is done.
Thanks so much, Biemba.
Biemba, it's Bronwyn. Thank you so much for your presentation. At the start, you mentioned that when the patient had been diagnosed, she had met the palliative care team as an inpatient as standard practice. Is that for all cancer patients or just specific subgroups?
For palliative care, our aim is for every patient to have a palliative care assessment at diagnosis and first assessment. However, sometimes because of not
Biemba seems to have dropped out.
Yeah, she looks like she completely dropped off. Um, she was able
I
to
was going to say,
join. Yeah.
how amazing that palliative care referral happens so early.
Yeah, I was thinking exactly the same thing. I think there's an Irish population who expect an imminent death when we bring up palliative care, so it's really interesting that they do it at the point of diagnosis.
That feels the same here within the US. A lot of the doctors that don't routinely use palliative are very reluctant to even consider bringing them in early.
But I think there's such benefit from allowing them to be met by palliative care when they're well and able to, I guess, voice their, their concerns, their goals, their wishes, and things like that. But I think it's also about how you sell palliative care, or how you, it's more about symptom control and symptom management as opposed to end of life. And I think palliative care probably get a bad rap from that respect. And that's the, I guess, the reticence from both the community, but as well as the medical profession too, for not wanting to refer early.
I think sometimes the barrier to not referring early also comes from they feel like they can be that palliative care provider. And I think in some ways I can appreciate where they're coming from, but I also see where patients have a lot of gaps in the quality of care that they could receive if that referral was done early. And once they receive the education of the difference between hospice and palliative care, they're very interested in doing it. But for me, it's often convincing my providers that, the more people have support from multidisciplinary teams, the better their outcomes, the better they feel emotionally, even spiritually about their journey with cancer.
And what is the kind of end of life care in the US or in Australia? So in Ireland, people are very attached to their homes, and there's a lot of generational trauma around that. But we have there's a palpable need for people to be at home and to pass away at home. And we have a community structure to try and support that. It's not always possible, but we, to the best of our ability, with a publicly funded health service, we try and facilitate that with nurses and carers going into the home. But I'm just curious, is it more hospice based where you guys are, or is it community based?
It's more hospice based, at least as far as Portland, Oregon is concerned. And interestingly, patients can be divided in how they feel about that. Some people, that's absolutely where they want to be, is at home in their own comforts with their family around them. And then a lot of people really struggle with just the concept of dying and not being on the planet anymore. And so they feel more comfortable actually being in a hospital setting. They just let their symptoms get to the point where they have to be admitted and they end up passing away in the hospital.
I've found that family members actually aren't always comfortable with bringing the patients home. They are the ones,
Agreed.
they push the admission more so than the patient themselves, even if the patient's wishes were to pass in their home. We try to, or at least where I'm out of, we do get hospice involved, but it can be a home hospice. So a visiting nurse would come in and take care of some of the needs that the patient has and teach the family how to do it. So it's interesting to see how different some families and communities.
Yeah.
Yeah,
Sorry,
here in Australia, which I think is a little bit in contrast to Sarah's experience in Ireland, it's a lot more hospital based. There's not that connection and expectation of dying at home and dying with your family. Of course, that does vary according to the community and cultural background. So we have a lot of patients in hospitals, and we can have palliative care type wards, but then some of the hospitals also have more hospice areas as well. We do also offer home palliative support, but that's probably less of a percentage than patients passing away either at home or in palliative care units, in hospital or palliative care units, sorry.
It looks like Biemba is back in also. So I don't remember
Okay.
exactly where we left off, but it was definitely with palliative care.
Hello, can you hear me?
Yes.
Biemba, I'm curious to know how palliative care operates where you are. Is it a community service, or is it based around centralized like the cancer hospital is for you? Was this patient be able to get palliative care in her local community or not?
Um, so our palliative care service is still highly centralized because prior to HIV treatment with home-based care, and there was a lot of hospices, the actual huge issue and mortality was high. But once ART came in and people lived longer, the home-based care service fizzled out, and very few hospitals were left. So we came up with putting up palliative care because in the beginning, when our cancer hospital was opened, obviously we had a lot of advanced disease, and so we saw the need to have palliative care. But linkage to primary healthcare level and the community is still not well structured. And as a consequence, also because of myths and beliefs, you have more families or patients being brought back to the hospital, even when they've reached end of life. So in our society, I think people would rather die in the hospital than die from their homes. And then also, sometimes it's because, death is not something we talk about, or the concept of death and dying. So when we introduced it, it was a bit difficult even for us as healthcare workers. But slowly, I think people began to appreciate the value of having this service and also talking about the fact that they had crossed that threshold from curative intent to palliative, and then they become end of life. But our families would still require a lot of support and having the difficult conversations. So, like you saw from one of the things I raised was how do we strengthen the linkage between this specialized hospital and the communities where these patients are coming from? Probably we need to piggyback on the primary health care system because we do not have, like I think in the UK, you have the home, what you call, is it visiting nurse? The nurses that work in the community and go to people's homes. We do not have that here. So it's a bit of a challenge when a patient goes home to have continuity of care.
Do most patients have a primary healthcare provider? I know it's often difficult in Australia even to for people to have a general practitioner or a primary health doctor that they see. Is that something that your patients do have someone that they do see on a regular basis locally?
No, we don't.
No.
You're seen by whoever you find at the health facility when you show up.
Yeah.
So you're not guaranteed of having the same clinician at every visit.
It makes that
So there's
continuity of
that.
care, very, very difficult for people
Yes,
then having to,
it becomes difficult.
tell their whole story again.
Yes, and especially if your medical records have gaps, like obviously the file I accessed, and these are conversations we would have with the clinicians where sometimes somebody will not take a detailed history and they'll not document everything, so the next clinician still is not able to get the full story. And sometimes our clients, depending on their emotional state at the time of a visit, will not recall everything they were told. I've had patients whom, when you ask, what drugs are you taking, they'll say, well, I don't know, I just have a batch of pills. And that's not very helpful.
Yeah, so we also have like community nurses here in Australia that can go out to the home to assist with wound care, and also palliative care home visiting as well. They have access to that. So I guess it's difficult for women when they're looking after themselves as far as wound care in this situation, to be able to manage if they don't have someone like that that can come and assess how it's going or change the plan if need be. And my other question was going to be around the follow-up. So obviously there was a long time between follow-up for her. What's the routine follow-up plan for a woman with vulval cancer, Biemba? Like how often would they usually be seen?
So the standard follow-up plan that is there usually is once you complete treatment, you're seen after 6 weeks. And then depending on how you're responding to treatment, then you're followed up like every 3 months in your first year. And then if you're okay, you're going to be followed up every 6 months for another 2 years. And then after that, you're seen annually. But patients are still told if anything comes up, anything happens, please do not hesitate to come back.
Yeah, and just to kind of add since I'm in radiation area as well, with these vulvar cases, as Biemba said, it will vary depending on how they're doing. As a lot of us know, some of them get really nasty skin reactions after radiation, especially if we have to dose the skin very high, which usually we do in the vulva, and even the distal vagina. Yeah, sometimes we see them frequently if they live close by, but that's here in Los Angeles. We get patients from out of state, out of the country. So, of course, then we have to figure out local care, but some of them need a lot of wound care and some of them do really well. It's just, yeah, as Biemba said, it depends on the patient.
Biemba, do you have visiting nurse services available to you or available to other parts of the country?
Well, something akin to visiting nurse services is what we call outreach, and mostly this is for maternal and child health services, because obviously our statistics for maternal mortality and infant and child mortality are not very good. So you have a lot of funding that supports this, but the same service is not really available for other conditions, unfortunately. There's something similar that has been started for tuberculosis because it is a problem, and obviously there is funding under those programs. So, and then the other issue, of course, is resources. Like this team has to go out, and maybe the institution only has the one vehicle. So, one thing we try to do with the palliative care team sometimes is if we have a patient that is out there and they're like on morphine, and they don't really have to come back in because they don't have problems, we would then coordinate with their local health service provider. When they come to the city, they come with the information about this patient, and we're able to get a medication refill that is taken back by the team that came to do something else. But that only would work well because you know somebody there, but we don't have an actual system that is intentional. So follow-up care is sporadic, like for those that are not in the facility, unfortunately.
I see. Thank you. Hopefully, because you have not, as you said, intentional programs for this, but maybe they'll be able to build one based on some of the templates of the other ones right now, like the tuberculosis and the maternal, those type. If they already have something in place for going and checking on them, it would be great to be able to build it up to include, even if it was one, nurse in that area for, it could be general oncology that's able to go and evaluate the patients and reach out to the team.
Yes, so one of the things is, thankfully, they're building two other regional hospitals, one south of the country, one a bit north. But also we did develop oncology nursing curricula. So we're having more oncology nurses trained. And then we are lobbying the government for nurse positions, not only at big hospitals, but within the district health system, so that then these nurses are able to provide the service, like you have said, at primary health care level. So that is the challenge that we still have, because I think until about 10 years ago, oncology was not really anybody's priority. And so people wouldn't really put money on it in terms of programmatic allocation. But now we actually have a National Cancer Control Strategic Plan, and we have prioritization of cancers. So like for adults, we have breast cancer, cervical cancer, prostate cancer, and colorectal cancer as priorities that actually are being funded. And then we have also pediatric oncology, the 6 index cancers under the WHO program. So we have made some strides. We're not yet where we want to be, but I think we're certainly not where we were 15, 20 years ago.
Yeah, that's incredible. Moving in the right direction for sure.
Anyone else have any comments or questions?
I think, just something that this is just another, another example of, healthcare across the world. I'm finding, and I'm talking very broken right now. I have thoughts going through my head and I'm trying to figure out how to get them out. Doing a lot of education around the world, primarily with brachytherapy, but also with just general radiation. I'm finding, there's barriers that are patient related and, resource related. And then there's barriers that are government related, such as, access to healthcare, but also just important things like a project we have with Nigeria right now, just equipment getting stuck in customs that can't get to the machines, and then their source can't get exchanged, or whether it's for external beam or for brachytherapy. And seeing it just in many different countries and across many different continents, and just, I wish there was a way, and this is way above my intelligence level, but a way to get governments to realize how critical this equipment is and get it through more quickly, or get vendor support more quickly. I don't have a good solution. It's just verbalizing, seeing this repeated pattern lots and lots and lots of places, and I just don't know how we can tackle it as a specialty. More just a statement of frustration and wanting to fix it without knowing how to do it.
I agree, Kayla. I think it's quite eye-opening when you hear the vast differences across the world in the options that are available to patients and
Mm-hmm.
government support or lack of government support across there. But I think as nurses, it's about us advocating for our patients and to get them what they need, when they need it, where they need it. But I think, as Chrissy said, Biemba, it's fantastic that you've now got an oncology nursing program, which is amazing, and that the government, you have an oncology strategic plan, and the government is seeing the importance in, I guess, those more common cancers, or those cancers that are probably have higher rates across your country. So yeah, definitely a step in the right direction, but unfortunately these things are a slow to change, but yeah, heading in the right direction.
Yeah, it definitely gives me hope that I know that we can keep moving things. It's a great example from you, Biemba, and just coming back from Colombia, another, great example is LDR brachytherapy is while I practice HDR, LDR is a great option for countries that are hit hard by, the machines going down. But even Colombia, they said we don't practice LDR anywhere because we can't. The seeds aren't. The government allowing the seeds in is basically there's rules against it, so they don't even try. So it's very eye-opening. I think we got a lot of work we can do as nurses to advocate and help what we can, and especially through education. But yeah, I think as oncology globally, there's a lot of opportunity to try to keep things moving, just learning a lot as we go here.
I would say also that we have one of the most robust cervical cancer screening programs, I think, in sub-Saharan Africa. This was started in 2005, obviously, after seeing the association between HIV and development of cervical cancer. So people were no longer dying of AIDS, but they were living long enough to develop cancer. So for cancers like breast, it's also beginning to piggyback on the programming that is already available for cervical cancer. So cervical cancer screening, at least, is available almost countrywide now. The only aspect of cancer care that's still lagging a bit behind and is highly centralized is obviously treatment, and then also, supportive care. So if treatment can catch up, and the fact that we're going to have 2 additional centers, I think is a step in the right direction, bearing in mind the cost of radiotherapy equipment. So it is a huge investment for a country like ours that is LMIC. So hopefully in the next 10, 15 years, we will see a much better picture, and we will have more and more oncology nursing services available at lower levels of care, not just centralized. So again, we keep on learning. We look at other countries. The only, I think, area where we still have a lot of work to do is obviously generating research that is local. So for there, we actually need a lot of capacity, because most of what we have, especially for nursing, is obviously just observational and anecdotal. But it would help if we could actually have data-driven by science to support some of the things we tend to talk about.
I couldn't agree more, Biemba. And I suppose it'd be interesting if there was, without the cameras on, a show of hands, has anyone got any active trials in vulval cancer? Because I feel there's a real paucity of evidence, particularly for vulval cancer. And I don't know of any trials that are open in Ireland at the moment.
So here in Australia, one of our nurses in Western Australia, which is the other side of the country from where Bronwyn and I are, has just started a local project, but hoping to go national around the use of like an antibacterial solution called Prontazan for vulval wound care after vulval cancer surgery. So I think both Bronwyn and my units are also planning to be a part of that. Because we as a group of gynae oncology nurses here in Australia have seen the issues that women have with vulval wound care, rates of infection, readmission to hospital, and things like that. So that is something that is planning to be started, in a few centres at the moment, so that we can get a standard of care. Because, as you say, a lot of the things we do as far as vulval wound care is all anecdotal, and there's actually no evidence behind, the sitz baths or the peri washes. People call it different things that we currently do. So being able to have a trial, when this is a nurse-led trial, around using a solution to help with vulval wound care will be fantastic. Because we definitely need the evidence behind some of the things that we do.
Getting close to being on the hour here. Drea, I know you started a topic conversation. I'm not sure if you want to table it or discuss it in these next final minutes that we have.
That's so nice of you to circle back to that. I was actually about ready to type in the chat that I have to go see a patient for teaching. So thank you so much again for this meeting, everybody. And this was a really incredible topic and presentation for the group. And then I'm sure it's something that is an ongoing thing here, so I can bring it up at our next meeting. Thank you so much.
Thank you, Drea. As Ashley just said, also, we are coming towards the end of this. And if there's anyone out in the group that's with us right now that wants us to discuss their case or they want to present their case at our next meeting, we really love getting input from this international community, and not just from the cases that we think are important, but from the cases that you think are important. So if anyone has anything that they really want to talk about, please feel free to email us. If something comes up next week and you realize, hey, it would be great, please email myself and Sarah or Ashley. And she just sent her email in the group, so even better.
Yeah.
Biemba, that was an incredible presentation, and I can't thank you enough for coming on and doing that with us and for us.
I'm also very thankful that you reached out, and the falling off and on notwithstanding, I've had an absolutely fruitful discussion, and I'm looking forward to the findings of that study that's going on about wound care, because like you saw already, that was one of our issues. And we do sometimes as nurses here, we do a lot of things like, you're going to use honey and stuff like that, but we do not have, the evidence to support what we're doing. So I think that is an area that would really be of interest. So I'm very, very thankful and looking forward to more interactions going forward.
Well done, Biemba. That was a really interesting case. Thank you for presenting.
Well, great. Thank you, everyone. Biemba, thank you for the case. As I said, our next echo is scheduled for May. We're doing these every other month. So looking forward to you all joining us in May. And like Chrissy mentioned, if you have a case, feel free to send that over our way and we can consider it for our next echo.